Folks, we are here again at the ASH 2023 meeting in the beautiful city of San Diego, talking a lot about so much data happening here at ASH. We can't cover everything, but we're going to cover a few important things. I'm here with Dr. Hamza Hashmi, who's going to introduce himself in a little bit to talk about his data in CAR-T. So Hamza, welcome to the HemOnc Pulse and Blood Cancers today. Just tell us where you practice and what do you do for research?
First of all, thank you for having me here. My name is Hamza Hashmi. I'm a physician at Medical University of South Carolina. In my practice, in my research, I focus on plasma cell disorders, myeloma, CAR-T, transplant. Excited to be here.
Thank you. So, there's a lot of data out there and so many abstracts, but you're focused in your research on CAR-T in myeloma. Before we go into the actual data that you're presenting, where is CAR-T in myeloma today? Like, where is it? Where does it fit, if any, today, December 2023?
Yeah, I think that's a very good question, first of all. As of now, December 2023, CAR-T is currently approved commercially for patients who have at least 4 prior lines of therapy. It's late-line relapsed myeloma, high-risk myeloma that is biologically more aggressive, and hence CAR-T is not a cure for myeloma as of now. But as we move further, I believe CAR-T is going to have FDA approvals for earlier lines of therapy, perhaps 2 lines of therapy. There are clinical trials that are evaluating CAR-T, comparing it against transplant for high-risk myeloma, and there are trials that are looking at CAR-T post-transplant. So I'm actually very hopeful that CAR-T is going to move in earlier lines of therapy. And that is perhaps the path, the holy path towards our goal for a cure for myeloma one day.
How many constructs are there available commercially, CAR-T?
Yeah, so as of now, there are 2 constructs. There's only one construct of 41BB co-stimulatory domain, but at least 2 CAR-T products are commercially approved. Ide-cel or idacaptogene viculeucel, and then cilta-cel, which is ciltacabtagene autoleucel. They're both commercially available. Ide-cel has more availability, I will say, at all major academic sites in the US that have the ability to freeze patients and administer CAR-T product. Cilta-cel is catching up. I think more and more sites are getting open and activated for CAR-T cell administration. And then there are some other CAR-T products as well in the development in clinical trial phase right now, autologous CAR-T, allogeneic CAR-T that are being evaluated.
So your group is presenting some data on CAR-T. I don't want to give it away. It's in frail and older adults. So tell us, first of all, why did your group decide to do this kind of research, and how did you conduct it? What's the methodology?
Yeah. So this abstract that is being presented as a poster is evaluating the outcomes of CAR-T in relapsed refractory myeloma, focusing on the safety and efficacy of elderly frail population. You may know that a pivotal trials for myeloma that has evaluated the role of transplant for myeloma, a determination trial, IFM 2009 trial, excluded patients who are above age of 65. There are barriers for commercial approval of these products in some European countries as well. Moreover, the clinical trials that have evaluated CAR-T in US and in Europe also have excluded very old patients, or more importantly, frail patients. Frail patients being defined by the performance status, frail patients being defined by their organ dysfunction. These are the patients that we see every single day in our practice. The median age for myeloma is 69 years. Many of these patients have renal impairment, they have organ dysfunction, they're not as physically fit, as an impact of the disease and not just the patient's age. So the goal of the study was to actually evaluate the outcomes in these elderly frail patients who we see every day in our practice and see if CAR-T is effective, and more importantly, if it's safe to give CAR-T, and somehow break this notion, this idea of CAR-T being not a safe option for frail patients.
Now, before we go into what you found and what the results were, this was retrospective, right? But before we do that, you mentioned performance tests, you mentioned organ dysfunction. Many would argue that that's not really enough, that you have to look at geriatric assessment for frailty and so on, because sometimes performance tests doesn't really correlate. In a retrospective fashion, I acknowledge you're not going to find the geriatric assessment. What are your thoughts about applying geriatric assessments as you look at things prospectively in decision-making for myeloma patients?
I think that's a very good idea that is being explored at major academic sites. having comprehensive geriatric assessment being a part of transplant eligibility evaluation. Age is number, physical performance status as measured by Karnofsky scale, and then HCTCI, which we have adopted or borrowed from our transplant colleagues, is being used to actually determine the impact of organ impairment on outcomes. I completely agree with you. If patients as elderly as 83, 84 are getting CAR-T products given, they should be evaluated by a geriatric physician. But not all academic sites in US that actually offer CAR-T or do transplant have that assessment available. They don't have the resources, it's time consuming. So we need to find better ways to integrate that into our evaluation and identify those patients, not just based on their age, but actually in fact their frailty, simplified frailty index guided by, to have them evaluated by geriatric physicians.
For my viewers, I have to say, before we go into the results, I don't feel that age is just a number currently. I have to say this. This applies only to me, by the way. Okay, what were the results of your data?
Yes, so in this data, we actually had a total of 130 patients, and 2/3 of the patients were defined as frail. Frailty definition was borrowed from simplified frailty index, as developed by Faken et al. With their analysis and data. With anyone who was above age 75, who had a performance status of 2 or higher, or who had a SCTCI of 3 or more, was actually getting a point. And we learned that 1/3 of our patients in clinical practice were actually frail. And we had these patients given CAR-T cell therapy, ide-cel and cilta-cel both. And we learned that in regards to the safety outcomes, the all grades and grade 3 or higher incidence of toxicities associated with CAR-T, CRS, ICANS, infections, were actually not significantly different. The only major difference which we found was that all grades ICANS was a little higher in these patients who were elderly, but grade 3 or higher ICANS was still not any different. We believe that perhaps related to more of a permeable blood-brain barrier in these elderly patients. One other findings that we noticed, again, what was clinically significant but not statistically significant, was higher treatment-related mortality in the frailer patient population. In regards to the efficacy outcomes, we did notice that these patients did not have as robust of responses. They were not as durable either. There was some difference in the progression-free survival that we noticed as well. And again, that is perhaps related to the more aggressive disease biology, impacting not only the performance status, but also the organ function, and hence translating into a higher frailty index score, and being these patients having classified as frail.
Congratulations on the results. I mean, this is really important, especially as more older and older patients receive treatment. But tell me, do the results that you're presenting affect how you would take care of patients today, or is it's good to know I need to monitor them? Are you going to not give CAR-T for somebody who may have in the 1/3 that you mentioned?
Yeah, I think that's a very important point, and that's perhaps the whole point of doing the study, that the study clearly establishes that a safety aspect, the safety concerns are not enhanced or augmented in the frailer patient population. The very reason why clinical trials do not enroll these patients, deny them the benefit of having access to a very effective novel therapy like CAR-T, is the risk of toxicities. They were not significantly different. In regards to the efficacy, I do think that a major aspect or element that drives the efficacy is the disease biology. Patients who are frail, they are oftentimes frail because of their disease, and not really their age or other physiological elements. So in my opinion, this study really and truly not only guides us to enroll these patients in trials and not be afraid by the risk of toxicities, but also commercially with insurance companies should not pose any major barriers towards giving CAR-T to elderly frailer patients.
Hamza, thank you so much for spending some time with us, and congratulations on your work, and I look forward to having you in future programs and look forward to seeing more of your work.
Absolutely. Thank you for having me here.
Thank you.